people, and they often have amnesia for other people doing things to them. If you really are serious about this, it's totally up to you. You don't have to be serious about it. You can just, check off the weeks on the calendar and talk the talk and not walk the walk. And you'll get your little certificate saying you've done the anger management course and you can go back. But if you're serious about loving your wife and loving your children.
There's been a request for louder. Does anyone else want louder?
Louder by me?
Yeah, is that better?
So it's louder if I hold it closer.
Okay, thank you. And does anyone else need a...
Not that loud. So if you're serious about this, there's a way of doing therapy that's probably not going to be paid for by the state. You'll probably have to invest some money yourself. It's arduous, it's painful, it's complicated, it's difficult, it's not a 3-week deal. And it will involve remembering what you've done and dealing with all the remorse and guilt about that. And then depending on how well I know the guy and what I know about his story, it's going to end up tying back into your dad beat you and your mom. And this is not just a learned behavior. This is also a whole bunch of very painful feelings inside. Now, if you're up for that, we can go for it. And it is possible to reverse that amnesia and remember. Because somewhere deep in your mind is making a choice not to remember. I mean, that's kind of a capsule summary, but that's the approach. So, we're... I guess I could explain borderline personality disorder from a structural dissociation model perspective in 1 minute. Well, see, it works like this. You just
from his website. I found him wonderfully enjoyable, but probably missed some of the more academic points as I was having too much fun. Interesting speaker with a wealth of material, clear, incisive, and informative presentation. Very good, intelligent, thoughtful presentation. Love his humor. Excellent, warm speaker.
Well, you wouldn't believe how much I had to pay for those comments. So, borderline personality disorder, I really am going to do like almost 1 minute, because it would take too long to go through it in detail. But basically, once you're thinking in this dissociative structural model way, all the criteria of borderline personality disorder fit in. And I'm going to come back talk more about borderline later in the day. So there's 9 criteria, you have to have 5 on a long-term chronic basis. You can't be borderline by just for 1 day. And in order to remember them, I put them in this mnemonic, A, B, C, D, 4 I's, and then the 9th one is short-term paranoid or dissociative symptoms. So anger, angry outbursts, so that fits the model, just the same reason as intermittent explosive disorder. Boredom and emptiness, that's chronic, really severe, intense chronic feelings of boredom and emptiness. So that's a withdrawal symptom. If you could just be selective and get rid of the feelings and the memories of the bad experiences, that would be great. But often you do kind of like defensive overkill, and you suppress the inner child in total, so you get rid of the spontaneity, the awe, the love of life, the fun, the connectivity, the relatedness, and you're empty and bored, so that's a withdrawal symptom. That's the withdrawal side of the model. Cutting is a behavior, but the purpose of the cutting, 99 times out of 100, is to push the feelings down. So people who self-mutilate chronically, virtually, I don't know exact percentage, but huge majority, are very good dissociators, so they don't feel the physical pain. But it's like an instant rush to your brain. So probably the pain signals go up to your brain and actually you release endorphins. So it's probably chemically, literally like shooting heroin. But anyway, it's a withdrawal. The behavior forces the withdrawal.
In that category, cutting, is it, sometimes I see this person, but instead of cutting, they're doing extreme tats, pierces, scarring, and it's all pain related.
So this is a little bit politically dicey, because the question is tats and piercing. So of course, and ritual scarring, which of course is on a spectrum. So it can be purely recreational, moderate degree, perfectly fine, And it's not the behavior in and of itself. So I'm not a member of the tattoo police force, but many people do use extreme piercing, extreme tattooing as a trauma withdrawal mechanism. And so there the problem is not tattooing as such, just like the problem is not food as such, or alcohol as such, or sex as such, or gambling as such. It's when you do it in this compulsive, addictive, self-destructive fashion. But I agree that many different behaviors can serve the same purpose. Devaluation idealization is basically all or nothing, black and white thinking. And it's not just thinking, it's feeling, perceiving, speaking, physiological arousal is in these two separate compartments, which I'll come back to when I talk about attachment to the perpetrator. Intolerance of being alone is a secondary behavior. The reason you can't tolerate being alone is you're so emptied out and so alone and so disconnected, so that comes back to withdrawal. Identity disturbance is you don't have a unified, integrated, fluid identity. You've got a bunch of disconnected compartments. Impulsivity is just impulsive, self-destructive behaviors of many different kinds, which is the sudden intrusion of the impulse, which is an impulse control disorder. Instability of affect means feelings come up, feelings go down, feelings come up, feelings go down. So that's intrusion, withdrawal of feelings. And then there's dissociative symptoms. So, ultra quickly, you can easily take all the symptoms of borderline personality disorder, put them in a dissociative structural model. And I'm going to talk more about borderline later. Then we have schizophrenia. So now we're really in a separate category, genetic brain disease category. And many people in the mental health field know for a fact that schizophrenia is a genetic brain disease. Actually, in fact, that's not scientifically true. That's a whole half day to go into that in detail, but basically, for schizophrenia to be genetic, concordance in monozygotic twins would have to be high. Okay, so what on earth does that mean? Monozygotic twins are identical twins. They come from one zygote, one egg. If something is actually genetic, solidly, strongly genetic, then if you interview the first twin and you find out she's female, you can be pretty confident the other identical twin is going to be female, because gender is perfectly under control of genes. So concordance for gender in identical twins is 100%. First twin's female, female. First twin's male, male, no exceptions. Same for eye color, hair color. And there's certain diseases. If you have cystic fibrosis in the first identical twin, the other twin has it 100% of the time. No exceptions. If the first twin does not have cystic fibrosis, the other twin never has it, identical twins, because it's purely genetic. Of course, if the first twin is Chinese, the other twin is going to be Chinese. If the first twin speaks Chinese, what are the odds the other twin is going to speak Chinese? Pretty close to 100%. Proving that speaking Chinese is controlled by the gene for speaking Chinese? Obviously not. Because if you take one of these twins and adopt them at birth into an English-speaking family, lo and behold, one speaks English and one speaks Chinese, because it's completely coming from the environment. So just because concordance is 100% doesn't prove it's genetic. It could be purely genetic, purely environmental, or a combination. But in order for it to be genetic, concordance has to be 100%. If concordance is really low, then you know it's not genetic at all. And so in psychiatry, you look at the concordance for different disorders to see how genetic they are. And it turns out, when you average the best designed studies together, over decades, many different countries, when the first twin has schizophrenia, the other twin only has it 30% of the time. That simple fact, which is in the literature, replicated, proves absolutely, medically, scientifically, that schizophrenia could be at most only a little bit genetic. So there's a whole, bunch of arguments, and I have a whole series of slides to really convince you of that. So it just isn't actually scientifically true that we're dealing with this genetic brain disease. Do genes have nothing to do with it? No. But it's not, quote, a genetic disease in any kind of simple sense at all. Environment's got a lot to do with it. And I'm saying that schizophrenia in general fits the dissociative structural model. And I have a whole book about this called Schizophrenia, Innovations in Diagnosis and Treatment. Just like flashbacks are core to PTSD, voices are core to schizophrenia. So they're not some little incidental symptom on the side. In fact, in the DSM, there's rules. So there's criteria A, B, C, D, E, F for schizophrenia. A is the symptoms, a collection of symptoms. Then B and C has to last 6 months, and you have to have deterioration in function and some kind of distress. And then the other ones are basically, it can't be due to this or this or this. So to have schizophrenia, it has to last 6 months, you have to go downhill, and you have to have some of these symptoms. But there's a little note there saying you only require one symptom for the diagnosis if it's either voices talking to each other or voices keeping up a running commentary on a person's actions. So voices, according to the DSM, are the core of schizophrenia. And I say the same thing about voices as I say about all these other symptoms. Okay, I'll try not to forget that, thanks. Just voice tell me what to do there. Okay, so just like I don't have a water sipping compulsion, why do I not have auditory hallucinations? 2 reasons. I always say there's like 2 dials here. There's a volume dial and an ego alien dial. So to be a voice, it has to be kind of loud. You have to dial up the volume. And you have to dial up the ego alien. So voices are loud, and they're not coming from you. They're coming from outside yourself. It's somebody else, inside or outside your head, talking to you. And you can't control what the voice says. You can't turn it on, you can't turn it off. Sometimes the voices talk to each other, and you're just like listening, and you can't butt in. So it has to be very ego alien. If it's very, very quiet, it could be an ego alien thought, but you probably wouldn't call it a voice. So voices are out loud, and they're not you. So where are they coming from? The wall, the floor? No, they're obviously coming from inside you. So it's the same basic logic. You can't experience something coming from inside you as not coming from you, as being an out loud voice, unless it's in another dissociated compartment and it's intruding back in. So an auditory hallucination is not an intrusion of a combat scene, not an intrusion of abandonment fear. It's your own negative thinking, often talking to you out loud from another compartment inside your mind that you're hearing. And if we look at the core symptoms of schizophrenia, there's a guy called Kurt Schneider, who's a German psychiatrist, who listed these symptoms, so they're called Schneiderian symptoms. And they're the basic core of schizophrenia in all the literature around the world. Made thoughts, feelings, and actions. That's where your thoughts, your feelings, and your actions are made or controlled by some power or force outside you. Okay, so if your feelings, well, let's skip feelings for a second. If your thoughts are made or controlled by some power or force outside you, that's a symptom of the genetic brain disease of schizophrenia, and those are psychotic symptoms. Everybody clear on that? Okay, I'll say it one more time. If your thoughts are made or controlled by some power or force outside you, and they intrude into your mind, then those are obsessions, and you have obsessive compulsive disorder. No, wait a minute. Hold on. If your thoughts are made or controlled by some power or force outside you and they intrude in, that's a made thought, and that's a psychotic symptom, and you have schizophrenia. See the difference? So it's exactly the same process, and if it's a made action, then that's a psychotic symptom, except if the diagnosis is OCD, we call it a compulsion. But it's exactly the same experience and same symptom. We just put it in a different diagnostic category, we give it a different name, and we say it's due to genetic disease of schizophrenia. But if it happens in another person who has a label of OCD, we say it's due to the gene for OCD, and it's a compulsion. So we have different name, different category of the DSM for exactly the same thing. And beautifully, the vocabulary for schizophrenia actually fits the dissociative structural model perfectly, because symptoms include thought insertion, and thought withdrawal, where thoughts are put into your mind or taken out of your mind. Thoughts out loud, thoughts ascribed to others. There's somebody else inside my mind thinking thoughts, which wouldn't be possible if there wasn't a dissociated compartment. So when you walk through the symptoms of psychosis, they're all either withdrawal symptoms, which are called the negative symptoms of schizophrenia, or intrusion symptoms, which are the positive symptoms of schizophrenia. And then there's people who have really severe thought disorder where their cognitive processes are all just fragmented and discombobulated. That component probably doesn't fit the model. That to me looks like some sort of actual, cognitive brain short circuit thing. How do we treat schizophrenia? In mainstream regular psychiatry, we give meds, obviously. So that reminds me of a guy with a sore knee who went to a family doctor. So, see the obvious connection between schizophrenia and a guy with a sore knee who goes to the doctor? So the guy with a sore knee goes to the doctor. The guy who comes in the front door is the patient. The guy who is renting the office space is the doctor. He's got the white lab coat on, so we can tell the difference here. And the patient has a symptom. So the doctor takes a history, does a physical, comes up with a diagnosis determines treatment, and the doctor works with the patient, who's the one who has the symptom, to get rid of the symptom so that the patient no longer has the symptom. That's medicine. Okay. Down the hall is the psychiatrist's office. The patient comes into the doctor's office with the symptom of hearing voices. And the doctor interviews the patient and then comes up with a treatment plan to get rid of the symptom for the patient. So back to the general practitioner's office. How often does the general practitioner take a, okay, when did the sore knee start? Oh, immediately after you were tackled on the football field. Okay. Kind of a clue as to what's going on here. So you take the history. The doctor doesn't go, thank you. Now, knee, how are you feeling about things today? So the doctor doesn't interview the knee. The doctor doesn't ask the knee questions. Okay, back down to the psychiatrist's office. The patient, who's psychotic, the doctor who's sane, asks the patient questions. The patient hears voices. The doctor doesn't hear the voices, and the doctor doesn't talk to the voices. But the patient might talk to the voices, but that's because they're crazy. All clear? This is how biological psychiatry operates. This is a brain disease symptom. It has no meaning, it has no context, and we just want to get rid of it. Well, what's true about these voices? So some people with schizophrenia don't have voices. Some people have voices that are like, you can't even make out any words. Some people have voices that just go, die, die, die. But some people have voices that carry on conversations with each other or keep up a running commentary on the person's behavior. According to the DSM, that's all you need to have schizophrenia. Last 6 months, you go downhill. These voices keep up a running commentary on the person's behavior. They have a point of view, they observe what's going on, they scan the social field, they have an attitude, they speak English language sentences and paragraphs, and they have conversations with each other. And there can be an angry voice and a calm voice, a male voice, a female voice in schizophrenia. So these are voices that are people inside. There may not be any switching, so there's not dissociative identity disorder. Well, bad news, I talk to voices all the time. I ask the voices questions. I want to get the voice's point of view. I form a treatment relationship with the voice. And I want to integrate the voice back into the person. And when the voice is successfully integrated back into the person, there's no more auditory hallucinations. But the diagnosis is not schizophrenia, it's dissociative identity disorder. But the point of the book is there's a large subgroup of people with schizophrenia, if we give them that label, who could benefit from this kind of integrative psychotherapy. Because the voices are not just meaningless brain disease, dysfunction, short circuit. These are disowned, disavowed, pushed away, aspects of self that need to be soothed, healed, integrated, blended back into self. So we're back to the suppression versus integration model. Okay, so now somatization disorder. And then we'll be done with the dissociative structural model, except it'll be woven into the rest of the day. Somatization disorder is really separate from schizophrenia. I mean, that's really, so we're talking like far away separated categories. Schizophrenia and mood disorder are closer together, and there's an intermediate diagnosis called schizoaffective disorder. Substance abuse and eating disorders are kind of neighbors because they're kind of addictions. But schizophrenia and somatization disorder are really far apart. Somatization disorder, there's a list of 33 different symptoms. You have to have a bunch of them in different combinations for quite a bunch of time, and you have to go see a doctor about it. That's the definition. So you have psychosomatic symptoms, a bunch of them for a long time, and you go see the doctor about it. And there's nothing wrong as far as the doctor can tell. So somatization disorder never existed 5,000 years ago because there was no doctors. So if we could get rid of the doctors, we wouldn't have any somatization disorder. But of course, people would still have the symptoms, they just wouldn't go to the doctor for them. So going to the doctor is like completely a secondary behavior. What it's really about is the symptoms. And there's a paper that I actually read a few years back, written right around 1900, where a very learned, wise, coincidentally male doctor was saying that it's theoretically impossible for males to have hysteria. And it was published in a journal, and like this very learned article. And hysteria included somatization disorder, histrionic personality disorder, borderline personality, dissociative disorders, all kind of glopped together. So he was saying that guys just don't have somatization disorder because they're not a bunch of hysterics. And they have, important stuff to do in life, and they don't have days off to go shopping, doctors, and all that. There's actually a grain of truth to that preposterous male chauvinist pig stereotype. There is actually, in fact, an epidemiological link between being female, having a sexual abuse history, and having somatization disorder. You can be male, have no sexual abuse history, and have somatization disorder. That's perfectly possible. But those things tend to go together a reasonable amount. Female, sexual abuse history, somatization disorder. Why? Okay, what are the odds that if you're female and you were sexually abused as a child, you're going to have a sore elbow as a result? Nothing. It's got nothing to do with it. So lo and behold, this is rocket science here, so focus hard now. If you're a female, adult female, and you were sexually abused as a child, and as a result you have psychosomatic symptoms, it's not pain in the elbow, I wonder what it might be. Lo and behold, the evidence is very clear, it tends to be gastrointestinal, genitourinary, menstrual-related symptoms. Because those are the organ systems that actually took the hit, that were the brunt of the trauma. So when those symptoms come up, we call that somatization disorder. It's not flashbacks of Vietnam. It's not getting in a rage and beating up your wife. Now what's coming up is the body memories, the physiological sensation. So when all those physiological sensations are pushed down into the underground compartment, we don't have somatic symptoms. When the lid comes off and there's a sudden intrusion, what's intruding is a psychosomatic physical sensation symptom, and we call that somatization disorder, and put it in a completely different category from PTSD or OCD or schizophrenia. It's all intrusions. So depending on what it is that's intruding in, we put it in a completely different diagnostic section. And if you go through, I'll just go through this before I take a question. If you go through the list of symptoms in somatization disorder, there's intrusions of pain, unexplained or non-organic pelvic pain, and so on. And there's a bunch of withdrawal symptoms, where you go deaf, you go blind, you can't feel, you can't move your arm, trouble walking, weakness. So those are all the withdrawal symptoms. There's nothing wrong neurologically with your brain, you've just shut the program down. So all these things easily fit in a intrusion withdrawal dissociative structural model.
A little bit of controversy on with chronic pain, because the research today now finds that there's a chronic pain patients actually have a high incidence of sexual abuse history, and not so much they're always saying that it's the cause that more exacerbates the situation once they're in it, but you also get a lot of chronic pain patients where certain doctors will say it's psychosomatic, but nowadays you're getting also a lot more research where they're finding that people who've had an injury, car accident, back surgeries, and still will end up having to deal with a certain amount of level of pain that they'd have to manage, that they find that some of it is more of a pain system
Right.
disorder versus the injury's fixed,
Right.
but the pain system has been altered. And so the false alarm, the alarm that says, take your hand out of the fire, that alarm system keeps going off where you have to learn
You
to
mean there's
retrain
a
it.
sudden intrusion which wouldn't be happening in normal circumstances?
Well, that it happened due to an injury, but then they sort of say that it was
Remember?
fixed.
Hold on, remember, the dissociative structural model is a structural, not an etiological model. So
Right.
she's just saying, there's people with chronic pain syndromes. There's an elevated rate of childhood sexual abuse in the pain world, but some people just have a physical injury, it heals, but the pain system is not turned off and you have pain. So that would appear not to fit the dissociative structural model, but it fits perfectly because now the cause is not sexual abuse, the cause is the physical accident. But the problem is you got the switch on when it should be off. So that's an intrusion that should not be going on.
Correct. But is it more physical or more, because I'm finding with the medical community that
Well, nothing's
it's
purely
at
anything.
it's at odds with figuring out if when the person still has left with chronic pain, is it a psychosomatic disorder that they're looking at, or is it just a physical where the alarm system has been altered?
This is the problem with the whole society, the culture, the mental health field, medicine. Because you're asking a perfectly legitimate question, which is a completely ridiculous and absurd question at the same time. Because you just said, they're trying to figure out, is it psychosomatic or not? Wait a minute. Psychosomatic. Everything in the world is psychosomatic all the time. There's nothing that isn't psychosomatic. So the world operates as if we have these separate categories, and now we're in the somatic category. Oh no, we'll put them in the psycho category. They're probably female hysterics who have pain for no legitimate somatic reason. And then we do somatic treatment here, and those fluffy people over there do the psycho treatment. I mean, that's the world's divided up into these black and white sectors, and there's a failure of communication between the two sectors. When anybody who has the faintest understanding of the whole universe of chronic pain knows it's a hugely complicated mess of psycho and somatic all the time. So, but even if we're back to it's a structural, not an etiological model, there's an intrusion that should not be happening.
Correct.
And so you want to not have the intrusion. So it's all, if you do an on-off switch model, where the intrusion is the on and the withdrawal is the off, everything turns into on-off switches, all of life is on-off switches, basically.
With the somatization, and it's usually in reference to female child abuse, but what about male child abuse and male sexual abuse survivors, as far as that kind of the disorder manifesting itself in maybe physical ways? Is it different systems of the body, different places?
There's actually Richard Clough, who's one of the dissociative identity disorder gurus, had a very illustrative case of a guy who had all kinds of neurological workup for this very odd kind of rectal pain that nobody could find any cause for whatsoever. And when he came to Rick Clough and did all the work about the sexual assaults that he experienced, pain was gone. So I mean, there's only one chromosome that differs between men and women. All the other chromosomes are the same. And so that's why if you are male and you have a sexual abuse history, you don't have menstrual problems, but you have other psychosomatic problems. So you're going to be more likely in the gastrointestinal system or genitourinary, where you won't have the menstrual. So it's just a variation on theme. It's kind of like being culturally sensitive. So, I've lived in the Canadian Arctic and hung out with Native people tons and spent 2-3 winters without running water living in the Canadian Arctic. I've been over to China 7 times and have 8 or 10 publications with Chinese people. So I think I'm kind of like reasonably culturally sensitive. But I'm actually not interested in being culturally sensitive. I see that there's differences. I can kind of tell that men are different from women. I've noticed that much. But I'm more interested in the similarities in what people have in common. So with the trauma parents are 90% women and 10% male. So I think I'm like reasonably good at working with female trauma survivors. But I'm more interested in the trouble that they have as human beings, not the gender-specific or the culture-specific aspects of it. But I also have a series of publications on cross-cultural syndromes and trauma and dissociation. So I think it's important to emphasize the similarities more than to exaggerate the differences. So here we're back to just a reminder of the theme. We've got the executive self, the wounded child in the underground compartment, and is the plan suppression or integration? And here's what at dinner last night, some person who was trying to disturb my dinner and cause me to be agitated said, it'd be nice if I said something about treatment outcome. I won't name any names here. Well, her name actually is Andrew. So I threw a couple slides in which weren't in the initial handout, so that's why it's a separate printout of these slides. And this just illustrates the kind of treatment outcome data that we have. So we have admission, discharge, 3 months, and 2 years follow-up. And this is the SCL-90 is a general all across the board mental health symptoms measure. The Beck Depression Inventory, the Beck Suicide Scale, the Beck Hopelessness Scale, and the Dissociative Experiences Scale, which measures dissociative symptoms. And here we have admission and discharge, which includes, it's admission to and discharge from the program. So half the people only did inpatient, so they were there about 12 days on average. Half the people, everybody did inpatient, half the people did the day program for a couple of weeks. So the overall average stay in the program, inpatient and day combined, is about 19 days. And what we see is, this is just numbers, but this is big, clinical, obvious, in-your-face difference. The Beck Depression score is dropping from 40 to 25. Suicide and hopelessness score